Okay, thank you for that introduction. Let's see. Okay, so those are my disclosures and also disclaimer that my employer makes me put on everything. Okay, so I always like to start with a little bit of epidemiology. So mainly we're going to be talking about PrEP, but PrEP is obviously prevention. So if you're preventing, you got to know what you're preventing and how much of it is out there. So the good news on prevention and HIV transmission is that over the last 20 years or so, HIV transmission is down a lot, and it's down by 50% overall, and down almost every area in the world. But interestingly enough, one of the few areas of the world that it actually increased over that time was this area where we are now. But of course, that was increased from an extremely low base to just slightly less extremely low numbers. So I know it's still low, but going up and not going down as it is in other places. But with the good news, there's always bad news, and the bad news is that even after that reduction of 50%, there's still 1.5 million new infections per year throughout the world, and I think we can all agree that that's too many. So the UNAIDS and WHO have their guidelines on HIV prevention, and now is the 5 pillars of HIV prevention, and the one all the way on the right side is antiretrovirals for prevention. So that would include things like TASP or treatment as prevention and PEP, but really the mainstay for the antiretrovirals prevention is PrEP, and that's what we're going to be talking about in this session. So, in terms of like where we are in PrEP in the whole world, I like this website. It's from AVAC, and it's called PrEP Watch, and they update, really almost in real time, or at least every quarter, where is PrEP being distributed in the world, how much of it is out there, and country by country data. So this is where things look right now, and the darker the color is just the more PrEP that's being done in each one of those areas. And you can see the area we are there's really no color there. So I know it doesn't mean that there's no PrEP being done in this area, and later in this session, I know we'll hear more about what is being done in the area here. But at least what's being reported, centrally or recorded, centrally, not very much so far. But they do list. I was going to say. So the total, if you look at there, is about 2 million people started on PrEP throughout the world at the end of 2021, so as of the end of last quarter. UNAIDS put a target out a while ago for 2020 of 3 million. So we're 2 years past 2020, and we're still not anywhere near 3 million. So we're really behind in PrEP in what the UNAIDS targets were. And they have a target for 2025 that's 10 million. So that's 5 million. I mean, that's 5 times more than what we have now, just in the next 3 years. And maybe we'll get there, maybe or not, but it's an ambitious target. And really what it means is there's a lot of people out there who meet our criteria for PrEP. They meet whatever criteria people have, but they're not getting it yet. So there's really just a lot more PrEP that needs to be done, and really needs to be done if we're going to decrease the number of new infections, and hopefully eventually end AIDS or come close to ending it. So on that same PrEP Watch, they list all the countries that have, like national programs, some kind of national program for PrEP. And I tried to see, how many were in this region, and really there was only 2, in the Middle East or North Africa region, and that was Israel and Morocco. And if you kind of dial, if you hover your mouse over the different countries on that map, I'll show you like how many PrEP starts there's actually been. If you go to Israel, it says 0. I'm sure there probably is some PrEP going on, but not reported. And then Morocco had about 1,500, so a little bit more. But that was it for the area. So not a lot, at least, is on the radar screen for what's going on. So why has PrEP rollout been so slow? So I know there's going to be sessions later on that are going to talk more about this, so I'm just going to hit the highlights here. But there's a lot of reasons. So I think really, the first 2 are probably the most important. So structural issues, and one is kind of the ART approach. So like, where does ART get done, right? It gets done in a special clinic, by special doctors, oftentimes special days of the week or special days of the month. Use special drugs, you do special blood tests to follow up. Everything all special, and it just means you need a specialist, and it's just hard to access. It's a barrier for people to get to those special places. And usually those places are very few and far between, so people may have to travel a long distance to get there. Provider issues. So I think I heard some of this morning as well. Most people are not going to ID clinics or HIV clinics where PrEP is done. They're going to their primary care doctors, and most primary care doctors just don't have any training on PrEP. They don't know how to do it. They don't know where to start. They're not, probably most primary care doctors have patients who would meet criteria for PrEP, but most primary care doctors are not doing sexual histories on a regular basis. So they might even have a patient who needs PrEP, and the doctor won't know because they never asked the patient about their risk behavior. And then we heard a lot this morning, too, about stigma and discrimination, and I think that's a big issue, too, in PrEP. So one, doctors, they may not ask about, stigmatizing behavior because they don't really want to know about it. Or if they find out about it, then they stigmatize a patient, as a drug user or someone who has, deviant sexual practices, and the doctor feels like, well, that's not my job to take care of this person's problem, and that's a problem everywhere, including in my country as well. And then at the patient level, I think knowledge about PrEP is an issue, and I'll speak a little bit more about that in my personal experience. But a lot of patients may not know about PrEP, so they don't know to ask their doctor for it. There may be some concerns about safety, resistance as well, and then some, there might be economic reasons, lack of insurance or lack of money, or lack of access to health services as well. So for most of the rest of the talk, I'm going to talk about specific countries and how they've approached PrEP and how they're doing. I thought it's good to start in the U.S. because I'm from the USA. And in the U.S., and I be honest with you, I don't think the U.S. has done much better than most other places in this regard for PrEP. So we actually have 3 different PrEP regimens that are approved for use by the U.S. FDA. So most people know the TDF, FTC, and that's the mainstay of PrEP, and that's probably 98-99% of PrEP that's being done. It can be given daily or event-driven. But we also have TAF, FTC available, and the cabotegravir injection. So we heard this morning about the Cabla for treatment of HIV, but now there's some new data on prevention as well. And that was just recently approved for PrEP use in the U.S. I'll talk a little. I have a couple slides on the TAF, FTC, and cabotegravir because I think that's kind of new and most people probably don't know much about it. But uptake in the U.S. is low as well. So the CDC estimates about 1.2 million people in the U.S. would meet criteria for PrEP, but only about 300,000 have started so far. So really only meeting 25% of the need. And if you look at that graph on the right side, it shows that the uptake of PrEP in different populations, particularly if you divide by race, has been very, very different. So if you look at like MSM, who live in urban areas and who are white, they have very high uptake of PrEP. You can see about 66% or 2/3. But if you look at other populations, particularly racial minorities, African Americans, or Hispanic Americans, the uptake of PrEP is much, much less. And there's some barriers there, but really the barriers in the U.S. are the same barriers I showed in the last slide, the same barriers we're going to hear about in the next, in some of the next lectures. So really not much different, I think, in the U.S. than anywhere else. So I said I'd talk a little bit about the new PrEP formulations because I think there's probably less experience with these in the rest of the world. So everybody knows TDF FTC, but there's also TAF FTC that is approved for PrEP use in the U.S., and that was approved in 2019. So the TAF is it's tenofovir. It's just a different formulation of tenofovir that allows you to use a much lower dose of the tenofovir. So the TDF, is 300 milligrams of TDF. TAF is only 25 milligrams. So it's much, much less. But actually, due to the pharmacokinetics of the drug, the intracellular levels of tenofovir with TAF are actually equal to or higher than with TDF. So TDF, a lot of it gets into your blood and your plasma, and then the kidneys excrete it and never makes it intracellularly. But for TAF, a lot more of that gets intracellular and less is directly excreted by the kidneys. So that allows a lower dose, and you have less toxicity from the tenofovir. So if bone toxicity is an issue or renal toxicity is an issue, TAF is a lot more forgiving for that than TDF. And there was a trial called the Discover trial, and it basically showed that TAF was non-inferior or equal to TDF as PrEP. But there's some buts with TAF. So one is TAF FTC is approved for PrEP only for MSM and transgenders and not for women. So one of the issues is one, there hasn't been a study to show that it works in women, and probably won't be, because we do have data that shows that the drug concentrations of the TAF are much less in the female genital tissue than it is in the rectal tissue or in the penile tissue. So there's a biological reason why TAF may be less effective for women than it is for men. It also costs a lot more than the TDF. So TDF FTC is now available in generic, so the cost has come down a lot, but the TAF FTC is not generic. Well, actually, it is generic. There is a generic formulation that comes in India now, but I don't think it's distributed very widely in many places. Or oftentimes the TAF is also used for hepatitis B treatment. So in many countries you may have TAF available, but it's just TAF by itself. It doesn't come co-formulated with the FTC, and you really need the two of those for PrEP. And then just at the end, towards the end of last year, Gilead had been promoting TAF FTC in the EU, but they withdrew it from the EU basically because it said there wasn't enough demand. So it doesn't look, I think Gilead's not going to be pushing the TAF FTC as much in the future, and we may not see much availability. For my own personal use, I still find it useful occasionally, but not very much. Probably maybe 1 or 2% of my patients use TAF FTC, and it's really just the few patients, maybe it's an older patient who has indications for PrEP, but their creatinine is a little bit high, or the renal function is a little bit low, maybe not too low, but getting towards low, and you don't want to put them on TDF. So in those few patients, I think it is a useful drug to have. So the Cabla, we heard again this morning, used for treatment. Treatment, of course, it's used with 2 drugs together with rilpivirine, but for prevention, it can be used alone as a single drug, just given 1 injection every 2 months. There's a big trial, a couple of big trials. The results came out within the last couple of years, HPTN 083 and 084, that showed that Cabla was very effective. These were non-inferiority trials comparing against TDF FTC, but actually the results showed that the Cabla was superior, even though it was a non-inferior design, showed it was much better. Personally, I think that the Cabla is equal to TDF FTC in terms of its efficacy if it's taken as it's prescribed and meant to be used. But of course, we all know with TDF FTC, it only works if you take it, and not everybody who gets it takes it every day like they're supposed to. So the issue with TDF FTC is if you take it every day, it's extremely effective. It's 99.9% effective at preventing HIV. But people don't take their pills every day. They miss doses. They travel and they forget to take it with them. So a daily drug is very effective if you take it every day. But not everybody has everything together enough so that they can take the drug every day. Getting injectable every 2 months just takes away that adherence issue. You get an injection, and then for 2 months, it doesn't matter what they do. There's nothing to forget to take every day. So I think the Cabla is going to be, for people who don't want to take a drug take a pill every day, or can't take a pill for every day, then the Cabla I think is going to be very, very useful. Now it is, like I said, it's approved and being used for treatment already. It's approved for PrEP as well. It was just approved in December of 21 in the U.S., but it's not yet available. You can't actually buy it and use it yet. So for the treatment, again, it's 2 drugs, and when you buy it, it comes with 2 drugs. They're actually 2 different injections that you have to give, but when the hospital or the pharmacy buys it, they come the 2 injections together in 1 box, and there's no way you can buy the Cabla alone by itself now. So the company said, this is GSK, said it's going to be available sometime early 2022. I haven't seen yet available in the U.S., but I think it should be available sometime soon. So getting back to, like how are different countries doing with PrEP? Prior to moving back to the US about 2 years ago, I was based in the other end of Asia, Southeast Asia, for 18 years, and 6 of those years were in Thailand. I worked at the Thai Red Cross AIDS Research Center. So I was there from 2013 to 2019, and while I was there, we started up a PrEP program, and it was actually the first kind of like publicly available PrEP program in all of Asia. So the Thai Red Cross has a VCT. It was the first VCT in Thailand, opened in 1992, and the biggest VCT in Thailand. So before COVID, they were doing over 40,000 HIV tests a year. And if you do the math, that means some days we had over 200 HIV tests in a single day. And back in November 2014, PrEP had just been added to the Thai national guidelines. So it was in the guidelines. And at our clinic, we just had really high prevalence rates of HIV. So for the MSM who came into the clinic, prevalence was 20%. For the non-MSM, their HIV prevalence was 6%. And we also had a program to screen for acute HIV infection, like people had been infected within the last 30 days. So we had data in real time, like which groups of people HIV is being transmitted in right now. And we could see that even though MSM were 30% of the clients coming into the clinic, 90% of all new infections or acute infections were MSM. So we knew that there was this really big transmission of HIV among MSM at the end of 2014. So we knew that we had a problem. A lot of HIV transmission. PrEP had just become available and approved in Thailand. And we thought, well, how are we going to get PrEP out to the people who need it? So first thing we did was say, well, what do you need to do? We didn't have PrEP. There was no PrEP clinics. There was like almost no PrEP clinics in the world at that time. We said, well, what do we need to start PrEP service? So we just came up with kind of this checklist. So you need the people to work in the clinic. So you need somebody who can prescribe, whether it's a doctor or a nurse. You need to do the HIV counseling. So you need a counselor. A pharmacist to dispense the drug, somebody to draw the blood as well. This doesn't even have to be 4 people. And I mean, some places you can have 1 person who does all this, or maybe it's 2 or 3 people who do that. You need the lab services because you have to do HIV testing before you give PrEP. You need creatinine because the main side effect of TDF affects kidney function. So you need creatinine before you start PrEP and then follow up. Hepatitis B testing, should be done. You actually don't need hepatitis B testing to start PrEP, but you do need it to stop PrEP, right? Because the PrEP drugs are also treatment for hepatitis B, and if somebody had hepatitis B that was, not identified, you may be treating it, and if they ever stop PrEP for any reason, they could get a rebound of their hepatitis B. So you really need, the hepatitis B is more important for stopping PrEP than for starting it. And then STI testing is nice, to have as well, but it's really kind of optional. You don't have to have that for PrEP. You need to have a pharmacy so you can dispense the drug. And if you look at, 1, 2, 3, if you're doing ART services, you've got 1, 2, 3 already. So all that's taken care of. So you really can just go straight to 4, which is, preparation. So there's guidelines out there, but guidelines doesn't tell you, how your staff is going to implement it. So you need to take those guidelines, put it into a protocol, an easy to follow protocol that your staff can follow, and then you train your staff to do it. And the one thing you can see that I didn't put up in there is money. We didn't have any money to do this because we were a nonprofit organization, and you could try to get money from your government or from international donors or something, but that's going to take a while, right? It's going to take 6 months, a year. It may take many, many years. So we did this actually without any money, and I'll show you how we did that. So from the time we came up with this, idea until the time we actually launched it, it just took a month. Because like I said, we had step 1, 2, and 3. It was already taken care of. We just wrote a protocol, trained our staff, and did it. And we did it without any money as well. And the way we did it without any money is we just charged people, our costs. So we were a nonprofit agency. We didn't have to make any money on this, but we did need to cover our costs because we didn't have any subsidy. And we were lucky because we had access to the low-cost generic drugs from India at the time. And at the time, when we started this, it was about $15 US per month for the PrEP drug. So I remember the first talk this morning. I heard something, 5, 6, 7,000 dirhams per month for ART. Yeah, and I'm trying to do the conversion to US dollars, and it's kind of that's what it costs in the US too. It's rich countries, it's all about the same. But if for low and middle income countries, you have access to the low cost generics from India, and that changes the economics a lot. So we were able to start the service, charging people our cost, and we did it for basically 30 Thai baht, which is about $1 US. So when we started, it cost about $30 US per month for the patient. And that covered everything in cost. It covered the cost of the drugs, it covered the cost of all the testing as well. We could actually get reimbursed from the Thai health insurance system for the HIV testing. So at least for the Thai nationals, they didn't have to pay for the HIV test. We could get that covered, but for foreigners, they would have to pay for that itself. As the cost of the drugs came down over a few years, we were actually able to cut that cost for the patients in half. So when we first started the program, we called it PrEP 30. And 30 just meant 30 baht per day. Or about $1 per day. And 30 baht sort of has a meaning in Thailand because that's also what, if a patient goes to the hospital or a healthcare provider in Thailand for anything at all, they have a copay is 30 baht. So that's kind of, in their minds, that's what you pay for a copay for visits. But as I said, we were able to reduce that by half when the cost of the drugs came down. So we did it in our existing clinic using existing staff. We didn't have to build anything new, just had to train our staff. We had a very simple protocol for the VCT counselors. The VCT counselors could follow the protocol, and they would, find if somebody sort of met criteria or risk for HIV, then they would refer to a doctor who could write the prescription. And like most counseling places, we had 20 VCT counselors, but only 1 or 2 doctors. So really, the counselors had to do most of the work. And then we could provide PrEP, at the first visit. So we did do an HIV test. We can get that test would come back as a rapid test quickly. The creatinine, I wish we had a creatinine rapid test, but we didn't. And most people starting PrEP are young people, and we just said, okay, we'll do the creatinine, we'll draw blood for the creatinine. We're not going to get the result back tomorrow. We get their phone number, and if the creatinine came back, high or something, we can call them and stop. And taking 1 or 2 doses of PrEP, I don't think is going to have, it's not going to have irreversible effects on their kidneys. So we just said we'll just do it that way. And this shows how many clients per month over about the first 5 years of the program. So when we first started, the uptake was really, really low. So I said, we had up to 200 people a day coming in for HIV testing, but at the first few months, we only had like 5 or 10 people per month. So, it was really low. So we had, 3,000 or 4,000 people a month getting HIV tests, and we're only starting 5 or 10 of them on PrEP, it's just like kind of 1% or maybe 2% at the most. And really what it was is, PrEP was something very, very new at the time. Most people had never heard of it before. They came to the clinic for an HIV test. They did not come to the clinic to take a pill every day for a long period of time. So when people would come in, we do the HIV test, they say, we have this new thing, and it prevents HIV. And most people, even if they were really high risk, they would just say no because they never heard of it before, and they were very resistant. But then as people came back and people heard about PrEP more and learned about it, then the uptake of PrEP increased. And it, after 4 or 5 years, we got up to 100 people a month starting PrEP. But it really took a while, and I think for the news and information about PrEP to get out to people before they really had big uptake. And then over 4 or 5 years, we got up to about 3,000 people cumulative over time. And there were some surprises. So one is, we really, designed this program for the local people, the Thai people who are at risk. But when we looked at the data, after a while, we found that about almost 40% of our clients were not Thai. They were foreigners. And they could have been foreigners who were working in Bangkok because a big expat population, or just visitors, people visiting from the region. And we had people from everywhere from Afghanistan to Zimbabwe who started PrEP. We looked at the data. Most of them were either from China or other places in Southeast Asia. A lot from the Western countries as well, and I think most of them were people, foreigners who were working in Thailand. I did look at the data, see how many came from this region around here. Out of 3,000, there was 23, so it was a small number. And those are the countries that they came from. At least the people told us. Not everybody reported where they came from. One from Dubai, I looked, exactly 1 out of 3,000. And also, we looked at data in terms of, what are the risk factors, people coming in, particularly, based on, what was their risk group, the MSM, heterosexual females or males. I mean, of course, there's a little differences there, but we really want to focus on the bottom was, this group is like either had no risk or other risk. And that, when we first started collecting data, that wasn't even a category. It wasn't a box to check because we didn't think about it. And we only added that later on when the counselors were saying, or, people come up with other risks, or some people really just couldn't have any, identifiable risk factor, but they really wanted PrEP for some reason. And we decided, this is not going to be a barrier. If they really want PrEP, we're going to give it to them, even if their risk is from oral sex, which we all know is very, very low. But I've been doing this for 30 years, and I've met people who say, I got HIV from oral sex because I never did anal sex. That's how they got it, and it's low risk, but it happens. So if somebody says, if they use condoms all the time for anal sex and vaginal sex, but they still have oral sex, I'll still give them PrEP. So lessons from the Thai Red Cross. So one is that PrEP road is going to be started quickly using existing facilities and staff. And at MSM and other people, if you provide PrEP, at a low cost, in a friendly environment, people are willing to take it. Not everybody, not all at-risk people are going to fit nicely into our high-risk categories. Helped that we had the low-cost drugs available from India, and the demand is there. Offer the service, and the clients will find you. I think we started about 5 minutes late. Is it okay if I go a few more minutes?
No, this is the timer. You have 1 minute already.
Oh, I got one more. Oh, 1 minute over. Yeah. I think did we start late though? That's. Oh, that's the start. Okay. Then I'll stop there, and then if there's questions, we'll wait till the end, right?
Thank you.
Okay, thanks.